Good evening, everyone, and welcome. My name is Shirley, and I will be your moderator this evening. I am excited to welcome Dr. Vijay Parashar, a diplomat of the American Board of Oral and Maxillofacial Radiology and a leading faculty member at Midwestern University, as our speaker tonight for an informative discussion on airway analysis in the dental practice. Before we get started, I would like to take a moment to go over some housekeeping rules. If you have a question, please type it into the Q&A section, and we will answer them live at the end of the webinar. CE is not available for this webinar live or on demand. Dr. Parashar, welcome, and thank you for being with us tonight. I will pass it over to you now.
Thank you so much, Shirley. Thank you so much for all of your help. Let's get started. So as Shirley said, the topic today is airway evaluation. And thank you so much to all of you. We have a lot of participants that are joining us. And thank you so much for joining us this evening. First of all, thank you to all of you for taking time away from your families, practice, and joining us here today. I'm also grateful to Henry Schein for giving us this opportunity to connect and talk about cone beam CT and its application for airway evaluation. I'm especially thankful to Dr. Gary Severance. He's Senior Director at Henry Schein. We discussed the topics, and Patty Oppenheimer, she was also very helpful in coming up and designing the webinar for today. And I'm also thankful to Corinne, who helped us with organizing the webinar, and Shirley Velasquez, who is here from Henry Schein, and she's joining us from Paris. It is middle of the night. I'm really grateful to her for helping us organize and deliver this webinar to all of the attendees this evening.
Presenter is not employed by or hold any stocks, options in any cone beam CT imaging company, dental implant company. Presentation includes images that may be privileged and confidential and cannot be reproduced without written consent of the presenter. This academic activity is intended to be scientific and educational in nature. This presentation is focused on interpretation of CBCT images and not intended to act as or to replace manufacturer training on a specific software or a specific CBCT scanner. The opinions, conclusions, experiences, and views expressed in this presentation are of the presenter. Clinical images have not been manipulated or falsified to mislead treatment outcomes. All content, including text, images, audio, or other formats, were created for educational and informational purposes only. This content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of the physician or other qualified health provider with any questions you may have regarding a medical condition. The existing literature and guidelines referenced in this lecture may get modified at a future date. Please continue following updated guidance from dental and medical authorities.
All right, with that disclosure, it helps us because we have a lot more participants that have joined in the last 1 or 2 minutes. But after this disclosure, let's briefly share my background. This is the dental school in India. This is where I received my initial dental training, which was Bachelor's of Dental Surgery. Came to States, and I had to repeat my clinical years, which are the 3rd and 4th year, which I did at University of Detroit Mercy. And my maxillofacial radiology residency and Master of Dental Science I completed at University of Connecticut, Farmington, Connecticut, and I finished it in 2006. And for the last 15 plus years, I have been interpreting cone beam CT scans. And I'm really grateful to my training and to my mentors that I get an opportunity to share little knowledge that I have on cone beam at all over the country, different dental association meetings. This was midwinter in Chicago, Texas, Michigan, and we have a lot of attendees today who are joining us from all over the country. And I have delivered similar content even internationally. Let's start with the beginning. On the left of your screen is the first ever dental radiograph. This was made by Otto Volkow. He was a German dentist. He held a photographic plate in his mouth for 25 minutes, and this was the product. So I'm sure we have patients who are concerned about radiation dose in our practice, but talk about the radiation dose here. Over the next 100 years, the quality of dental imaging improved, and all of you get images like this in your private practice with two-dimensional conventional dental radiographs, where you are able to see any kind of secondary caries or if there is an open margin on any of the restorations. But still, this was two-dimensional imaging. It is still lacking the buccolingual information. And that is corrected or addressed by a cone beam CT scan. So again, we have a lot of participants here, and Henry Schein sells a lot of units. And I'm really grateful to Dr. Severance and Patty that I discussed with them that I will not speak about any one unit or any one machine. Today's webinar will be generic, irrespective of the machine that you have. The information that we are going to discuss, you will be able to use it tomorrow morning in your practice. So irrespective of the machine that you have, the discussion will be relevant to you. And I'm grateful to Henry Schein for their understanding and letting me talk about just the modality and not any specific unit. Okay, so very briefly, what makes cone beam CT so much special? Why are we discussing about it this late in the evening? So let's compare it with fan-shaped CT. This is medical CT, helical CT, or hospital CT. The shape of the X-ray beam is a flat fan-shaped beam. So if hospital CT, you have to image your patient, this flat beam will have to spin around the patient's head, spiral around the patient's head multiple times. Whereas with cone beam CT, the shape of the X-ray beam is shaped like a cone. It can cover, that's how it gets its name, cone beam CT, and it can cover a much larger surface area in one spin. And this is what reduces the radiation dose. Again, irrespective of the machine that you have in your office, irrespective of the software that you have in your office, all of you will get images like this with your CBCT scanner. Top left, this is an axial view or a horizontal view. This view is coronal view. This view is sagittal view. We will look at these views a little bit more, but let's look at this axial view, top left corner. This is a really good view when you are trying to identify root canals. So this is at the level of the tooth roots, and you can see the canals really clearly. If you are trying to do endo evaluation on your cone beam CT scans, you're trying to identify canals, find canals, look at this axial view. This is a good view when you are trying to identify your root canals. Coronal view is a great view when you are trying to look for symmetry, when you are trying to compare right side to the left side, you are trying to figure out if there are any changes in the anatomy, any pathology. Here on the coronal view, you can compare right to left. Let's look at the top right view. This is a sagittal view. It's a very thin sagittal view. Wherever we have this green line, if we took a magical saw and cut this volume such that you're able to eliminate all of the tissue on the right and the left of this thin white line, just this tissue, which is represented by thin white line, is what we are seeing in the top right corner. This is a sagittal view. This is a really good view when you are trying to look for periapical pathology. Like in this case, you can see tooth number 8, periapical area. It has a periapical radiolucency. In addition, we have 3-dimensional volume rendering on the lower right side of your screen. This is a good view just to get a broad overlay, just to take a look at the entire volume in 3-dimension. And it's also a good patient education tool. Patients are able to see teeth a little bit easier or anatomy a little bit easier. But coming back to this top left screen, in addition to the root canals, I'm sure all of you who are looking at these images are able to identify that there is almost like a cookie bite appearance on these central and lateral incisors. So you have external root resorption going on with tooth number 9 and tooth number 10, which you again can see really well on the axial view. Okay, let's quickly look at some more screens showing us different views. Axial view is the horizontal view. And again, I will be using these terms quite a lot over the next 40-45 minutes. So axial view will be horizontal views. If we took a magical saw, cut the volume where these dotted red lines are, you will be able to create these kind of images. Sagittal view, vertical cuts. Again, today we are talking about airway. So this sagittal view, we will look at this image quite a bit. This is like a mid-sagittal view right in the midline. This is the image that we are looking at. This is good when you're trying to identify airway, look at airway, when you're looking at cervical spine, and you're looking at periapical pathology around root apices. This sagittal view will be helpful. Coronal view, wherever we have these dotted red lines, if we took a magical saw, cut the volume right here, and we're looking straight at the patient, and you will be able to compare right-sided anatomy with the left. And again, this kind of a view in the middle right section on your screen, we will look at a lot of these images today. Learning objectives that we have selected or identified for today's webinar, we'll look at advantages and limitations of imaging for airway evaluation. We will have a discussion on scanning protocol. How should you position a patient? What are the effects of scan resolution? And which scan resolution or setting should you be selecting if you are trying to do airway evaluation? We will also briefly review anatomy, which you will see when you are looking at airways. And we will also look at current literature and discuss validity, reproducibility, and clinical significance of literature related to airway evaluation. There is a large volume of airway literature that is available. There's a lot of interest. Any good journal, dental journal that you will pick up, pretty much every month there is a new article, new research, new interest that is being discussed regarding airway. So this is a really hot topic, and I'm glad we are discussing it today. Regarding the first objective, the advantages of cone beam. Cone beam is offering us a large amount of information. And this is really good information when we are looking at hard tissues. So when you're looking at teeth, when you're looking at bone, maxillofacial bone, which is holding the teeth together, this is a really good image. And airway space, the dark area can be reconstructed. All of the softwares that you have in your office do a great job showing a lot of colorful images, which I will show you shortly. But here with cone beam CT, we are able to create an airway volume. Scan time is extremely short. It's usually 10 seconds or shorter than that, and relatively low radiation dose. Again, today's webinar, we are not talking about numbers, but generally speaking, cone beam radiation dose will be about 400 times lesser than hospital CT scanner. But again, it depends. The specific dose will depend on scanner that you're using and the imaging protocol that you select. Some other considerations that we should keep in mind when we are talking about airway and cone beam. Cone beam is offering you a large amount of information, which is an advantage, but also that means we have larger volume that you need to review, look at, make sure there is nothing else going on the scan. And again, we said this is great to look at hard tissues like teeth and bony structures, but it does not provide us good information for evaluation of soft tissue or soft tissue pathology. What that means is if there was A tissue tumor you might not be able to see on your cone beam scan, but again, specific situations will differ. And another disadvantage or a shortcoming or limitation of cone beam is patient is awake and they are seated or they are standing, depending on the unit that you have in your office. So the airway dimensions might vary when the patient is laying down or sleeping. Field of view. Depending on the unit that you have in your office, you might be getting different field of views depending on what do you want to evaluate when you do airway evaluation. You might have to go with a large field of view scanner. So to the right side of your screen, a volume or a scanner which gives you a field of view this large will show you all the way from frontal sinuses to epiglottis. Whereas a scanner, which is imaging something like this, an image that looks like this on your, the second image on your screen, that might not give you complete information of maxillary sinuses or frontal sinuses. So again, depending on what you want to image, you might have to select the appropriate field of view on your CBCT machine. And look at the field of view your unit can capture and the anatomy that you are trying to image. Another difference is the effect of field of view on the resolution. Let's briefly talk about the image resolution that you see with your cone beam scanner. And again, this is not comparing different CBCT units. It's just within your own unit, depending on the settings that you choose, the resolution of the image will vary. So volume element, which is this little cube that we see on our screen, this is the smallest building block of a CBCT image. So if we try to imagine the image on the right side of your screen, to build an image like this, the software had to stack up a lot of cubes, these little cubes, to create this 3D volume. And the resolution is a factor of the size of this cube. If you are with your setting on the machine, if you select a smaller volume element size or smaller sized cube, you can stack more cubes to create your image and you will get a higher resolution. Why do we not always stack most amount of cubes, get the shortest dimension or setting on your machine and get the highest resolution image? Because it also increases the radiation dose to the patient. Again, briefly talking about it. So for airway or routine imaging, if you're just doing implant imaging or airway imaging, the dimension of this cube is adequate if you select a 0.2 or 0.3 millimeter setting on your machine. But if we were looking for a missed canal, if we were looking for a root fracture, you will have to select this dimension closer to 1/10 of a millimeter, which will be about 10 microns or 0.1 millimeters. Another disadvantage with using higher resolution for all the scans, it also increases the possibility of patient movement because higher resolution scans take longer and they deliver higher radiation dose to your patient. Patient position. How should the patient be positioned when you are taking a scan for airway imaging? Teeth are in occlusion. If you look at this image here, the teeth are touching. There is no bite block. There is no cotton roll which is separating maxilla and mandible. Teeth are touching. And we have tongue position should be passive. Unlike panoramics, where we used to tell our patient to touch their tongue to roof of their mouth, which they never did, with cone beam, my recommendation is ask your patient, do not say any instruction about the tongue and let them leave the tongue passive. And occlusion plane, the mandibular plane should be parallel to the floor, and cervical spine, which we can see back here, this should be straight. Patient should not be slumped into the unit. Patient should not be slumped. They should be sitting or standing straight in the unit. So these are some recommendations for your patient positioning. So what are some of the areas that we should review when we are doing airway assessment? And I have been asked by a lot of practitioners, what all do I report? What all do I look at when I'm creating a report for airway evaluation? For sure, if I'm creating a report for airway evaluation, I will give you the airway volume, I'll give you cross-sectional area measurements, and I will show you what those are, what's the clinical significance of those. I'll talk about the nasal cavity. We should look at the internal valve, if there is any septal deviation, if there is any bony spur formation, what are the changes, if any, with turbinates, and I will show you examples of all of these. We should also look at sinuses. If the sinuses are blocked, patient is not getting any air. So irrespective of what the measurement is that we're getting on airway evaluation, we should also look at the sinuses, and I will show you some examples of sinus pathology. We should look at both maxillary and mandibular teeth if they're captured on your scan. But for sure, we should look at maxillary teeth, and if there is any periapical pathology around maxillary teeth, which could be draining into the sinus and causing sinusitis or maxillary sinusitis of endodontic origin, that for sure has to be reported. But we should look at maxillary and mandibular teeth and look for any pathology. We should also look at tonsils and adenoids. I will show you some examples of adenoid tissue and if it is enlarged or not, and what's the significance of it. And since we are working very close to the cervical spine, we are right next to cervical spine, we should also look at the changes, if any, in cervical spine. Arthritic changes, if there is osteopenia that you observe in cervical spine, that should be reported. Or if there's some other pathology that you're noticing, that should also get reported. And if there is any other incidental pathology that you come across when you're reviewing a scan, that should also be reported. So these are some of the things that I look at when I am creating a report for airway evaluation. Measurements. What are we measuring? So we are looking at airway volume, we're looking at total volume, and we're looking at the most constricted area. Airway, we're looking at nasopharynx, oropharynx. These are the numbers that you see. One is total volume, which is the entire airway that is imaged. Second number will be minimum cross-sectional area. Before we get to that, let's quickly review some of the anatomy that is relevant when you are looking at airway. Here on the posterior pharyngeal wall, this is where adenoids are present. Take a look at the airway. This is where adenoids are. Adenoids, as we all know, just a quick recap, this is lymphoid tissue and posterior superior, which is back here, posterior wall of pharynx. It's part of Waldeyer's ring. It's physiologically present during 6 to 10 years of age. But if you see it and they atrophy, that is, this thickness recedes, it becomes smaller, it does not look inflamed or swollen after 16 years of age. And if you notice lymphoid hyperplasia, that is enlarged adenoid tissue in an adult or somebody who's older than 16 years of age, and they have chronic inflammation, this should be reported to their primary care physician or to an ENT. So I have been talking for a good 20 minutes. Let's have some interaction. And Stephanie said that, Shirley said we can use Q&A. So let's take a look at these two images. What do you guys think is going on with the adenoids? Do they appear normal or enlarged? What do you guys think? Which is the appropriate choice, A or B? Let's see if you can use the Q&A function. Okay, beautiful. Dr. David Zalewski, he's the first one, which is awesome. He's saying enlarged. Awesome. We have a lot of answers. Great. Awesome, awesome, awesome. So we are getting, thank you. So you can hear me and you are still here. We have a very large number, and now suddenly a lot of responses are coming and everybody is is going with enlarged. You are absolutely correct. If you look at the image on your screen, this is normal adenoid tissue, just for comparison that I have added, and all of you are correct. It appears enlarged. So if you see this in your patient, there is merit in reporting it, sharing it with their primary care physician. Awesome, thank you. More anatomy, real quick. So here we have ethmoid air cells that drain into superior meatus. We have maxillary sinus. This is maxillary sinus ostium, this tiny little pathway through which maxillary sinus drains into the nose. Just sinuses, frontal sinus, ethmoid sinus. We have nasal septum here. Internal valve. This is the junction between upper lateral cartilage and the nasal septum. So nasal septum and the cartilage on the right and the left. So the normal angulation between nasal septum and internal valve should be 10 to 15 degrees. But if it is smaller than that, that is representing a constricted valve, and that should also be reported. So in addition to the airway measurement numbers, we should also look at internal valve. Nasal cavity, we should look at the nasal septum, whether it is deviated or not. We should also look at the turbinates. So this will be middle turbinate, really easily visible on the scan. And this structure will be inferior nasal turbinate. So let's take a look at this one real quick, since you guys are doing so awesome and using the Q&A. What do you guys think? The nasal septum, is it straight or deviated? Okay, beautiful. So this one, Dr. Vadviker. Okay, amazing. We have a lot of doctors, Dr. Dixon, everybody's, yes, you are correct. This is deviated. In addition, there's one more finding. Unlike the previous scan that I showed you, the middle meatus here appears to have pneumatization, which is a fancy word that it is filled with air. So here we have pneumatization of middle meatus. It's called concha bullosa. This is a variation of normal anatomy. Usually you do not have to report this. You do not have to send this patient to their physician. But if this patient had sinusitis and you saw concha bullosa, then there is merit in sharing it with the physician, because it could be that the concha bullosa is constricting, or it is plugging the ostium and the sinus is not able to drain into the nose. In that case, you should refer it to the ENT or physician. But something like this, where the sinus is clear, life is good. More structures, frontal sinus, nasal bone, ethmoid sinuses, sphenoid sinuses. One more example here, more anatomy. Sinus looks clear on the left, right, not so much. Here we can see the open ostium, nasal septum and fundibulum, formation of bony spur, ethmoid air cells. All of those structures should be looked at when you are doing your airway evaluation. Another quick question. So ostium, does it appear patent, or another word is open, or do we think it's plugged or closed? So all of you, when you're looking at it, you can tell that it is not patent, it's not open, this is plugged or closed. Something like this, where you have maxillary sinusitis, you have plugged ostium, you should share it with the physician or an ENT specialist, and they should look at the patient's sinuses. So on the right side of your screen, this is a different case, unrelated case, just for comparison, which is showing you open ostium. This is what normal looks like. This is abnormal. More structures, lacrimal canal, circle right here on the middle of your screen. Infraorbital canal, both sides right underneath the orbit. We are seeing it here on a horizontal section or an axial section. Maxillary sinus, maxillary fissure, compare it, both sides, left side to the right side. If there is any expansion, any asymmetry, that needs to be investigated. We have ear canal, which is nice and open. Sphenoid sinus. Let's look at some sinusitis cases real quick. So here, maxillary sinusitis, right side, left side, both of the sinuses have buildup, there is sinusitis going on. Something like this should be referred to an ENT, and they should look at the patient's sinuses. So irrespective of what the airway volume we are getting, if both the sinuses are plugged, patient is not getting much air, and we should refer it or share it with the physician or ENT. In addition to the soft tissue buildup, we are also seeing some calcifications, these white opacifications that you see here. More examples, another case, unrelated case. Again, we have sinusitis. In addition, you have calcifications within the sinus. So these, what do they signify? These are dystrophic calcifications, and these could be calcification of fungal hyphae. So if we see calcification in a chronic sinusitis sort of a situation, again, you should refer it to the physician or an ENT, and they need to figure out whether this is fungal sinusitis or not. But again, if you see a calcification, that should be reported on your report and referral to the physician. More examples. A different case, here we have the right-sided sinusitis, left sinus looks clean or clear, and you have calcifications. Again, it could be possible fungal sinusitis. Another change which you saw in a couple of previous cases, look at the thickness or the width of maxillary sinus wall. Here on the right side, the wall appears thin, corticated. When we look at the left-sided maxillary sinus, yes, there is soft tissue buildup, there is fluid or soft tissue in the left maxillary sinus, but another change that you see on this scan is thickening of the wall of maxillary sinus. So this is a sclerotic change. This is seen with chronic long-standing infections. Even in the previous scan, when we look at it, look at the width of the posterior wall of the right sinus. Left sinus looks beautiful. This is normal. Again, coming back to it, here the right sinus is normal. Left has sclerotic change. This is something that should again be reported. In addition, if we look at this scan, do you see these small circular radiolucent or dark areas? We can even see it up here. This one, this one, this one. So these are air or gas pockets. What do they signify? This is telling us that you could have anaerobic bugs which are growing in the maxillary sinus. So this is acute sinusitis, which is producing air or gas bubbles, and that should again be reported on your report when you are referring it or sharing it with your physician or ENT colleague. Okay, same case, we are looking at this patient. Look at the left maxillary sinus, ostium is completely plugged, left maxillary sinus is completely full, and you have air gas pockets. This case was referred to an ENT, and patient came back 3 months later because they were edentulous, they wanted implants, and before placing implants, they wanted to clean the left maxillary sinus. This is what the 3 months follow-up looks for the same patient. And again, when you compare, there is no sinusitis now, or there is refractory thickening of the sinus wall, but the sinus is not filled up. And this is the surgical procedure that the ENT has performed, which is FESS, or when you compare it to a normal scan on the right side of your screen, you can see this anatomical structure, which is uncinate process that has been removed by the ENT to gain access into the sinus, and they have removed all the sinusitis. So this is functional endoscopic sinus surgery. That's a procedure that the ENT would have performed for this patient. Okay, good, let's keep going. All right, in addition to maxillary sinusitis, so we saw maxillary sinus, right maxillary sinus, left maxillary sinus. In addition, because when you're looking at airways, you also capture sphenoid sinus, which is this sinus up here. Another image, another image. So let's look at the right sphenoidal sinus on this patient or on this scan, which looks clear or patent. It should look empty. It should be air-filled. That is what sinuses are supposed to look like, which is this one. But when you compare that to the left side, again, similar sort of a process is going on in sphenoid sinus, just like multiple cases of maxillary sinusitis that are shared with you, where we have soft tissue or fluid buildup in the sphenoid sinus. In addition, if you look at the width or the dimensions of the walls of sphenoid sinus on the left side, they appear thickened. There is thickening of these walls. Again, all of these are signifying we have sphenoidal sinusitis, and the scan was done for TMJ and airway evaluation, and we noticed sphenoidal sinusitis. And for such a patient, you should ask them if they get frequent headaches. Usually these patients complain of headache at the cranial vault, at the top of their head. That is where they feel frequent headaches. But again, something like this, if you notice these changes, it should be shared with your physician or ENT. Okay, let's look at measurements. And these measurements that we looked at, which is here, which is total volume, and we have minimum cross-sectional area. Are these measurements clinically significant and reliable? Again, this was a study that was done. They looked at smallest airway, looked at a variety of demographics of patients. So that was one way they came up with these numbers. And second thing is they looked at patients who had obstructive sleep apnea, that they already were diagnosed with sleep apnea, and they looked at their airway when they were awake, when they were seated or standing in a cone beam machine. And that is where these numbers come from. So again, if we look at it, we have two numbers. One is total volume, which goes from posterior nasal spine all the way down to epiglottis. That's the total volume. Second is most constricted area. The research shows us that probability of airway obstruction is low when the smallest cross-sectional area is larger than 110 millimeters. So again, this is probability. Because patient is awake, patient is sitting or seated in a machine, it does not take into account the tissue laxity. So when the patient lays down, the tissue could fall back. But other than that, these are the numbers. If it is larger than 110, the probability of having airway obstruction is low. But if you observe that this number, which is minimum cross-sectional area, like in this patient, which is 32 millimeters square, which is lesser than about 50 or 52 millimeters square, then the probability of this patient having obstructive sleep apnea is high, and they need to be further investigated. This is the relevance of the numbers. Okay, so let's look at some more information here. So here we have airway volume measurements. So what are some of the things that we need to be conscious of? The airway volume, total volume, depends on the 2 points that the operator is picking. So we go from posterior nasal spine all the way down to epiglottis. And on this image, I've tried to show you what these anatomical structures are. If you look at this mid-sagittal view, this spinous process right underneath the nose, this will be anterior nasal spine, and the midline counterpart of it will be posterior nasal spine. So when you are deciding the vertical height of your airway evaluation or airway volume, start at posterior nasal spine, and the inferior extent goes all the way down to this soft tissue fold. This big density, this will be soft tissue of the tongue. This soft tissue fold will be epiglottis. So the vertical height extends from posterior nasal spine all the way down to epiglottis. Another thing, this big tissue that I'm trying to show, this is tongue. If the patient swallows or if this tongue moves, that can also vary or alter the airway numbers. There was this study which was done to see if the airway numbers that I'm sharing with you, are they reliable on cone beam CT images? And again, this study shows that yes, they are reliable. Let's quickly look at some incidental findings that people came across or when we were looking at airway. So a scan was done for airway TMJ evaluation. But again, this is an example of phrenoidal sinusitis. Let's look at another one here. Here, this will be the airway. And I'm sure all of you are noticing that there is a soft tissue mass which is growing or encroaching into the airway here, right there. And on the bottom right of your screen, we have a normal airway for comparison. So something like this, if you observe it, notice it, again, this should be referred to an ENT or primary care physician. Another example, so this is not directly related to airway, but again, maxillary sinus pathology. Scan was done, and here we can see that there is a soft tissue mass which is filling up right maxillary sinus, left maxillary sinus, in addition to normal anatomical structures. This is middle turbinate, inferior turbinate, we cannot even identify it. Floor of nasal cavity, we cannot identify it. Here on the midline view, we should see hard palate here. We do not observe it. It's all soft tissue density all the way into sphenoid sinus. We just have one single density. There is resorption of bony structures. Again, today we are just talking about airway, but these features, when you observe these features, they are pointing us towards something not good, and it should make us think of cancer. And a biopsy was done, punch, and it came back as adenoid cystic carcinoma or adenocarcinoma from minor salivary glands that are present in the palate. Let's look at a couple other cases. So here we have a scan. You can see the airway looks really good, but right behind the airway, this is the clivus or base of the skull. This will be C1. This is C2. And again, there is something different about C2 than the previous examples that I have shown you today. Another example, this is case B, which looks similar to case A, but in cases A and B, C2 vertebra, does it appear normal or abnormal? So again, I'm sure all of you are looking at it and are ready to type in your answers. But again, on the right side of your screen, here I'm trying to show you what a normal cervical vertebra looks like. So this will be C1. So C1, which we are observing here on case A, and a little bit of it, we are seeing it here on case B. So C1 looks good, but C2, this has two parts, which is C2 body and C2 odontoid process, which is also called dens. This should all be joined one single vertebra. But in both of these cases, cases A and B, okay, let's see, we have some of our doctors answering, which is great. Yep, Dr. Joanna Tesonero, she's the first one to answer. It is abnormal. Yes, thank you so much. I'm glad you guys are paying attention and still listening to me this late in the evening. You're awesome. Thank you. So yes, it is abnormal. So what's going on? What do we do with it? So even though we were looking at airway and these structures are just adjacent to it, you might catch it, you might see it when you're doing your airway evaluation. And that is why I'm bringing it here today. This is called os odontoideum. This could be an anatomical variant of odontoid process. Another thing we need to differentiate could be odontoid fracture. And this can lead to atlantoaxial instability. So C2 dens is the vertebra which helps us pivot our head. And if C2 dens is not connected to the body, C1 and C2 can move independent of each other. And that is what we say, that is what we are trying to say here, that it can lead to atlantoaxial instability. That is C1 and C2 can move independently of each other, which is not good because right behind it, this is brainstem. So if you notice something like this, please refer it to the physician for further evaluation and management as appropriate. Another example, so scan was referred by an endodontist, but when you're looking at the maxillary sinus, left maxillary sinus, I showed you a lot of examples of maxillary sinusitis, where you had thickening, you had sclerotic change in the posterior wall. But in this case, the walls are just destroyed. Walls are resorbed. Walls are not present. This is the posterior wall. It's good till here, then there is resorption. A little bit of posterior wall is remaining here, rest of it is eaten away. On this coronal view, again, a lot of bony anatomy is lost. Let's look at the sagittal view, which is like a very thin periapical radiograph. Here we have maxillary molar, but floor of maxillary sinus, which looks good till mesial to this molar, is completely resorbed, missing, lost, not visible distal to it. A lot of our doctors are responding, which is awesome. This is great. Thank you, thank you, thank you. You guys are amazing. Okay, so yes, you're all observing that posterior wall is not there. So this does not look good. Again, should be identified. This was the description, all the changes that we have discussed so far. This is the way I wrote it, and the biopsy came back as a lymphoma. Okay, let's take a look at a couple more images. So here we have an airway. We are talking about airway. So if you see something like this tomorrow morning in your practice, these are the numbers where we have total volume of 10 cc's, minimum area 50 millimeters square. What do you guys think? Is this normal or constricted? Okay. What do you guys think? Beautiful. Awesome. Okay. Awesome. Great, great, great. Dr. Garcia, Dr. Galindo, Dr. Wadweker. Okay, everybody's going with B. Yes, it is constricted with the numbers that we've discussed so far. But what else is special about it? So let's take a look at this. Same image. Looking at these two numbers, we all agreed that this was constricted, but let's push it a little bit further. So what do you guys think? Is it symmetrically constricted or is it asymmetrically constricted? And does it matter? Take a look at this. So here we are looking at the left boundary, left wall of the airway. On the right side, which is this side, there appears to be some soft tissue growth which is coming in here, which is resulting in more constriction of this airway. Let me zoom in a little bit more. What do you guys think? Is it symmetric or asymmetric? Does not look normal, right? Asymmetric, and yes, it matters. Yes, Dr. Joanna, yeah, a lot of our doctors are saying that, yes, awesome. It's changing so fast. Yes, it is asymmetric and it matters. So this is what it looks like. Axial view zoomed in. So in addition to the numbers, when you're looking at airway, try to see if it is symmetrically constricted, which I prefer, where it looks like a straw. Yes, it is constricted. We will deal with it. But if it is asymmetric, then we need to investigate why is it looking asymmetric? Why do we have soft tissue growth on one side, which is causing constriction and changing these numbers? These are some of the articles that I've found, which talk about different pathologies that can result in asymmetric appearance of airway. These are cases that have been reported where you have benign lipomas, or you could have a retention cyst, or you could have a hemangioma, you could have a tonsillar lymphoma, or carotid body tumor, which is again in the same proximity, or you could have a salivary gland tumor. So these are all different pathologies that have been already reported or published, which can cause asymmetric constriction of airway. So in addition to the numbers, look for asymmetric changes. Very briefly, incidental findings. There are a lot of incidental findings that can be observed on cone beams. So when you're reviewing it, look for the reason that you took the scan. If it was to evaluate for airway, great, but also look at other pathology that we discussed. These were some of the things when I get asked, what do I look at? A scan when I'm looking for airway evaluation. I look at the airway measurements. We talked about the significance of these numbers, airway volume. We talked about the cross-sectional area. I showed you examples of both anatomic and pathologic changes in nasal cavity, and I showed you a few examples of a lot of these changes. We looked at paranasal sinuses. We looked at the normal boundaries. We looked at normal sinuses. And we also looked at some pathological appearances in sinuses. Teeth, look at both maxillary and mandible if they are visible, but maxillary for sure because they could be resulting in maxillary sinusitis. Adenoids, all of us did a couple exercises, looked at normal versus enlarged adenoids. Cervical spine, I showed you some changes, even pathology with cervical spine, and we briefly looked at some incidental pathology. And these are some more additional resources, really good publications which discuss airway and cone beam. And thank you so much. And it is 8:51 Eastern time. This is my email if you guys have any questions. I told Shirley I'll be 50 minutes and we'll leave 10 minutes for Q&A, but we are very close. This is my email. If you guys have any questions, any feedback, you can send it there. We have good 10 minutes. I have nothing else to do this evening. Shirley has to go to bed. She's in Paris, but I'm here all evening. If you have any feedback, provide it to web, or maybe you want to run this.
Yes, thank you so much, Dr. Parashar. That was fascinating and so engaged, which was great. Great to see. Yeah, so we do have one question that's come in so far, and I want to invite everyone to please go ahead and enter your questions into the Q&A chat, and we will review them now over the next few minutes while we have Dr. Parashar. One question that we have right now comes from Dr. Tessoniero, and that is a 3D pano the same as a CBCT? If not, what is the difference? And I think you're muted, Dr. Parashar. There we go.
Yes, that is an excellent question. A 3D or a reconstructed panoramic is a pan that you can create from a cone beam CT scan. So 3D pano, you will need a cone beam machine to create a 3-dimensional or reconstructed pan. Okay. All right. We have
okay. We have someone, an anonymous attendee, who kept losing connection. And yes, a recording will be sent out over the coming week, so you will receive that. Another question coming in, well, actually more of a comment, great presentation from Dr. John Tukey. And we have also a question coming in from Dr. Ronald Weissman. Do we have to analyze or do we ask a radiologist to interpret since we don't have your training?
Okay. Again, this is a brief 50-minute presentation. This takes us into standard of care. So right now, as we stand, it is not a requirement for you to send your scan to a radiologist. It is not standard of care that every scan has to be read by a radiologist. I think you're doing the right thing, something that you're doing this evening, learning more about cone beams. I would say, look at your cone beams. If you have a question, yes, share it with your colleague. Try to use radiologists just like you use your other specialists. But I think cone beam is just like a panoramic. When we started with the pan, there used to be imaging centers and patients had to go to an imaging center to get a panoramic. Cone beam started the same way, but now it is present in pretty much every office. And Henry Schein is doing a great job getting it into every office. So I think we just have to learn this. I would suggest you to continue attending continuing education and get comfortable with it. But if you see something that does not add up, please get another pair of eyes to take a look at it. I hope you agree with that.
Wonderful. Dr. Tesoniero wanted to thank you for your answer earlier.
Thank you.
We have a
Thank you.
Dr. Zalewski who wanted to thank you for the lecture. Do you have any pathology texts that you recommend?
Okay, depends how much time you have. Send me an email and I will send you a list of few texts or few resources that you can use. But I can send you some.
Wonderful. Dr. Galindo, very informative. Thank you for a great presentation.
Thank you.
Also, Dr. Alsh, is CBCT, can it be used to predict OSA population or high-risk populations?
I think it's an excellent point, and I should have brought it up somewhere in my presentation, but thanks to Dr. Alsh for reminding all of us that yes, cone beam is an excellent screening tool. And cone beam, if you have taken a cone beam scan, whether it is for your implants, ortho, oral surgery, or any other purposes, you should look at it, and this can help you screen and figure out if a patient is at high risk for obstructive sleep apnea. So yes, thank you. It can be used.
And then we have a question from Dr. Barker. Can you speak more about the total volume and min area again? Also, the graphs that appear with the airway evaluation. And thank you for the presentation.
Yes. Perfect. Let's take a look at this image. So if you look at this image, the total volume, there are two numbers. There are two numbers. One will be total volume, which is from the height, which is posterior nasal spine, all the way down to epiglottis. And this number, total volume, I personally do not pay a lot of attention to total volume because this number varies. If a patient has a dolichocephalic face, if they have a taller face, this anatomy will vary and you will get a higher number with total volume. But the second number that we talked about, which was minimum or smallest constricted area, minimal cross-sectional area. If you have a constricted airway, I think that is more significant than the variation or in the size of total volume. And this minimum cross-sectional area, if it is less than 52 millimeters square, then there is a high probability of patient having obstructive sleep apnea. And if that number is larger than 110, then there is low possibility of patient having obstructive sleep apnea. Dr. Barker, I hope that answered your question. Yeah, thank you.
Very thoroughly. And we have a question from a comment really from Dr. Panu. It's a pleasure listening to Dr. Parashar, always learning something new.
Thank you. Thank you.
Similarly from Dr. Dixon, thank you, Dr. Parashar, for your presentation.
Thank you so much. Thank you so much for all the kind comments. Thank you. Really appreciate it. Thank you. And if you have any more questions, please feel free to email me. If you have an interesting case that you want me to share at one of the future webinars, or if you want me to take a look at your interesting case, please feel free to email it to me. That's my email. And this is the email for Henry Schein. If you have any questions about the webinars or and this is
we
the
have
link
one more.
Okay.
We have one more comment that just came in, Dr. Parashar, from Dr. Wadivkar. Great presentation, concise, clear, very good delivery. Thanks very much.
Thank you so much. I think it was a team effort, and I'm grateful to Dr. Severance, Patty, and the team at Henry Schein for helping come up with this topic and discuss it, bring it to you. Thank you so much. I really enjoyed it. Thank you.
With that, thank you, Dr. Parashar, for this amazing presentation this evening. And thank you, everyone, for joining us tonight. Like I said before, we did record tonight's webinar and email, and we will email the recording out sometime in the next week. We would appreciate your feedback via our survey that will pop up on your screen shortly. Thank you all for joining us, and we look forward to seeing you on a future webinar.